This conference will now be recorded.
All right, so we're going to talk about Chapter 7, Lifespan Development. Just trying to move a couple of things around on the screen so I can actually see it. All right, so we're going to meet the National EMS Education Standard Competencies for the EMT and EMS system. So lifespan development applies fundamental knowledge of lifespan development to patient assessment and management, kind of going through the different age years and what we're going to kind of see with these patients. And we start talking about like pediatrics and things like that. I'm going to bring my kid in, and there are other students that have offered to bring their children in as well. And I'm just curious to see how well you guys do with an assessment on them, especially when they're not near their parents. So we're going to learn about the different lifespan developments that are there and how we're going to be able to handle some of this. So humans develop throughout their lives, right? They start from being a neonate with the first 28 days or to 1 month for being born, doing infants, and moving its way up to the geriatrics and the elderly. So you have to be aware of the physical changes in a person that undergoes at the various stages of life. And this may affect the approach to patient care. Remember, they develop through the newborns and infants, and toddlers, and preschoolers, to school-age children, adolescents. Then there's 3 stages of adulthood, early, middle, and older. With that, you have to be aware of these physical changes. Again, it's really going to make a difference in how we're going to treat these patients. You guys will see that during your ride time, depending on what variety of ages you're going to see. So let's start with the neonates infant first. So neonates from birth to 1 month old. Infants are then from 1 month to 1 year, and they develop at a startling rate. And these kids, they grow and they grow quickly. So we're going to cover more about neonate and neonates in chapter 33 underneath the OB and neonatal care. But in the meantime, though, we're going to just kind of touch on this a little bit. Another thing to add also, those of you who are taking the CPR class, we always learn about pediatric, child, and adult CPR, right? I'm going to make a mention of this now. We're going to cover it more in chapter 33. New Hampshire has a protocol for neonatal resuscitation, which is completely different than what we learn in BLS CPR. And it's going to be a 3-to-1 ratio, three compressions to 1 breath. Where we normally look at 15 to 2, 30 to 2, in neonate, it's a different ratio. So we're going to keep that in the back of your head when we come closer to talking about CPR stuff. And then there's actually a whole specific class just with what they call NRP, which is Neonatal Resuscitation Program, which is offered by the AHA, which is a whole different program on top of the BLS CPR. So with this here, these are some things you might want to become familiar with because these will come back to haunt you later on in exams, including the National Registry, our vital signs. So we look at some of the physical changes in vitals. The younger the person, the faster the pulse rate and respirations, right? So at birth, a pulse rate of 90 to 180 beats per minute and a respiratory rate of 30 to 60 are normal. This is okay. This is what we want to see with these kids. Anything less than 60, even at a year old, we're doing CPR on these kids because that is considered clinically dead at that point. Their heart rate is just too low. So we're actually doing compressions by this. So shortly after birth, the pulse rate drops to 120 beats a minute. So it goes down from like 180 to 120 shortly after birth. And then the respiratory rate starts to fall between 30 to 40 breaths a minute versus 30 to 60. By 1 year, the respiratory rate then slows to 20 to 30 breaths per minute. With the blood pressure, directly corresponds to the patient's weight, so it typically increases with age. The average systolic blood pressure is 50 to 70 for a neonate and 70 to 75 for a 1-year-old. Remember that as far as weight goes, a neonate usually weighs 6 to 8 pounds, which would be 3 to 3.5 kilos at birth. The head accounts for 25% of its body weight, so keep that in mind, that they have big heads. After week 2, the infant then grows at a rate about 1 ounce, which is 30 grams per day, doubling their weight by 4 to 6 months and tripling it by the end of the first year. Right? Anything we do with pediatrics for medication is weight-based. 99% of the things we do are weight-based medications. So we have to get a weight. And weights are not done in pounds, they're done in kilos. So on the next practical day, just keep in mind, remind me, and I'll teach you guys the down and dirty way of how to do conversion from pounds to kilograms. But really, it's divide by 2 and take off 10%, and that gives you a rough estimate within a decimal point to how many kilos a patient weighs. With the cardiovascular system at birth, the neonate makes the transition from fetal to independent circulation. The pulmonary system, infants younger than 6 months are particularly prone to nasal congestion, and the rib cage is less rigid and the ribs sit more horizontal. This explains the diaphragmatic breathing in infants that we see. Infants also have proportionally larger tongues and proportionally shorter, narrow airways. So keep in mind with the airways on an infant that they don't have the cartilaginous rings that we would as an adult. Okay, so with their head being proportionally larger and their tongues being larger, their tongues then fall back into the airway. That's why I call them the devil tongues from the devil babies, because their tongues are so much larger, you got to get them out of the way to help them breathe. And because their head is larger than their body proportionally, it'll put them into a hyperflexion position, causing the airway, which remember, keep in mind, is very pliable, right, to actually close off, which is why we always pad underneath the shoulders of an infant to allow their airway to be in the neutral inline position. Airway obstructions, again, are more common in older children or adults, in infants than older in children or adults. Sorry about that. And for bag valve mask ventilation, remember that an infant's lungs are fragile. So too forceful of ventilation can result in trauma from pressure or barotrauma. So when you're giving somebody like a BVM and you're ventilating, you want to just keep in mind that as much as you can fit into your cheeks as you fill up your cheeks with air is about the tidal volume and amount of air you're going to be pushing into an infant. It's not much. And if you overinflate the lungs can pop. So respiratory problems can quickly become life-threatening with this. So infants who are struggling to breathe can quickly tire and become overheated and even become dehydrated with this. So again, kids like this can become dehydrated. They can become overwhelmed, overheated. So we want to make sure we're keeping them calm, cool, and collected the best we possibly can. With the nervous system, evolution continues after birth. So when the neonate is born with certain reflexes. So we have what they call the Moro reflex or the startle reflex. When a neonate is caught off guard, it opens its arms wide and spreads its fingers and seems to grab at things. The palmar grasp occurs when an object is placed in the neonatal's palm. So usually what I'll do is hold like a pen light and see if they can grasp it to check neuro. The rooting reflex is when something touches the neonate's cheek and it turns its head towards the touch. Then we have something called the sucking reflex, which occurs when the neonate's lips are stroked because it thinks it's receiving some of a bottle or a nipple at that point. These are all good neuro checks when you're doing any kind of an assessment, especially with something with a head trauma as well. Another thing you want to look for in neonates and infants as well for head trauma is the fontanelle on top. If it's a fontanelle is sunken in, usually it indicates dehydration. If the fontanelle is bulging out, usually its intracranial pressure is very high. So increased ICP. Which we're showing you here in the next slide after this one here. So neonates fontanelles allow the head to be molded. So the fontanelle is there, and the sutures are not all fully sutured for the bones. So it allows the bones to actually move inside to allow for expansion as they get older. They become fused by 3 months, the posterior fontanelle. And the anterior fontanelle fuses between 9 and 18 months of age. And I'll show you guys that in the next photo. If either of the fontanelles are depressed, the infant is most likely dehydrated, which we talked about before. And an increased cranial pressure if they're bulging out. With the immune system, the infants maintain some of the mother's immunities, but infants can also receive antibodies via breastfeeding as well. which will further bolstering their immune system. So it's always a good thing to allow breastfeeding for this because it can help with the immunity and build the immune system. So here's our mastoid fontanelle back here. If you can see my screen and moving around. Then we also have our sphenoidal fontanelle. Then we have our anterior fontanelle, the one on the top here, and then we have a posterior out back. The one on top, keep in mind, never actually push on these. But if you're going to assess them for sunken or if they're bulging or not, just run your finger over the top. If it indents in, at that point, you're going to have more of a dehydration. If it's bulging out and you feel a bump, we're going to have increased intracranial pressure. Some of the psychosocial changes we're going to see begin at the birth and evolve as the infant interacts with the environment. So as you can see looking through here, from 2 months to 12 months. I'm not going to read all these off, but you guys can see them on the screen. Just kind of an idea of what they do and how they move around, and just their different reflexes and psychosocial changes that they go through. So crying is the main method of communicating distress. So if a kid is crying, we got to find out why. The parents can often tell what's wrong just by the tone of the infant's cry. And with that, infants develop relationships with their parents or caregivers at different rates. Keep this in mind, though, that if a baby is crying and they're not consolable, then there's definitely a problem, especially if mom or dad can hold the child, mostly mom, but same thing with dad as well. If they're unable to console their kid, then there's something else going on. We need to figure out what. Some of the psychosocial changes, bonding is based on a secure attachment. So anxious avoidant attachment is found in infants who are repeatedly rejected. So you got to pay attention to that. Children show little emotional response to their parents and caregivers as well, and treat them as they would strangers. Another big one here is separation anxiety. So separation anxiety is common in older infants and involves clingy behavior and fear of the unfamiliar, especially different places or people. And then trust and mistrust also refers to a stage in development from birth to about 18 months, which involves an infant's need to being met by his or her parents or caregivers. If the environment also is not perceived to be as secure by the infant, a sense of mistrust will then develop. That's why anytime we do an assessment on a pediatric or infant, we always want to start at the feet and work our way up towards the head, so it helps us gain that trust. Okay, moving on to toddlers and preschoolers. So toddlers and preschoolers have a pulse rate between 90 and 150. Looking at the respiratory rate between 20 and 30 breaths per minute. Systolic blood pressure between 80 and 100. And a body temp between 96.8 to 99.6. Also keep in mind that a toddler's lungs also continue to develop more terminal bronchioles and alveoli as well. So we're starting to develop more with this as well. For preschoolers ages 3 to 6, we're going to see a pulse rate of 80 to 140, respiratory rate of 20 to 25, and a systolic blood pressure between 80 and 100. With preschoolers as well, weight gain should start leveling off at this point, although toddlers and preschoolers have more lung tissue. They do not have the well-developed lung structure, right? So you want to prevent them from sustaining deep or rapid respirations for an extended period of time, right? The loss of passive immunity is also possible in the most obvious development of this stage of human life. So colds often develop that may manifest a gastrointestinal disease or an upper respiratory tract infection. So you want to kind of pay attention to those. Toddlers also acquire immunity as their bodies. Their bodies are exposed to various viruses and germs. Because kids get into everything. Neuromuscular growth also makes considerable progress at this age as well. Some other things to keep in mind that toddlers and preschoolers also spend time exploring by walking, running, jumping, and playing catch. Preschoolers also have a brain that weighs about 90% of its final adult weight. Some other things is muscle mass and bone density start to increase. Physiologically, toddlers have the neuromuscular control capable of for bladder control by 12 to 15 months of age. However, a child may not be psychologically ready until 18 to 30 months of age for bladder control. Some other psychosocial changes, they learn to speak and express themselves by this age. At 36 months of age, basic language is usually mastered. Interaction and playing games with other children start to begin. By 18 to 24 months, this is a cause and effect begin to become understood, and children learn to recognize gender differences by observing role models. Uh, so keep that kind of stuff in mind. They're going to pick up different role models and learn the different gender differences. Our school-age children, vital signs approach those of an adult. Heart rate of 70 to 120, respiratory rate of 15 to 20, and systolic blood pressure of 80 to 110. At this point, obvious physical traits and body function changes become apparent now, which you have a growth now about 4 pounds or 2 kilos and 2.5 inches or 6 centimeters each year. Permanent teeth start to come in. Brain activity increases in both hemispheres at this point. And unintentional injuries are the leading cause of death in this age group as well. Some psychosocial changes, obviously on pre-conventional reasoning. Children act to avoid punishment and get what they want. Conventional reasoning would be children looking for approval from their peers in society. Post-conventional reasoning, where children make decisions guided on their consequences. And self-concept and self-esteem start to develop. So what they're looking for in the self-esteem as well is how they feel about themselves and how we fit in with other peers that are there. The adolescent teenager is 12 to 18 years. The vital signs then level off. Looking at pulse rate of 60 to 100, respiratory rate of 12 to 20, and systolic blood pressure of 90 to 110 systolic. So as you're seeing now in these adolescents from 12 to 18 years, you're seeing the same vital signs as an adult at this point. With this, girls, the 2 to 3 year growth spurt, girls usually finish by the age of 16, boys about the age of 18 on average. Growth then begins with the hands and feet, then move to the long bones of the extremities and finishes the growth in the torso as well. Muscle mass and bone density are nearly at the adult levels at this point. The reproductive system starts to mature as well. So secondary sexual development then starts taking place. The internal sex organs enlarge, pubic hair and axillary hair begin to appear, their voices start to change. In girls, the breasts and thighs increase in size as fat tissue is deposited there at that point. Menstruation starts to begin. By the middle of adolescence, boys are able to produce sperm and eggs begin to develop in girls. Another thing also is acne can start to occur due to hormonal changes, and unintentional injuries are the leading cause of death for adolescents. Some of the psychosocial changes, obviously adolescents and their families often deal with conflict as adolescents try to gain control of their lives from their parents. So privacy becomes an issue, self-consciousness increases at this point, and adolescents may also struggle to create their own identity. So when we're assessing these patients, we really need to pay attention to their needs. They want to be treated like adults, yet they are cared for like younger children. So they want to be treated like adults. They want to be able to have a conversation. So it's something in an EMS standpoint, when we're assessing them, separating them from their parents and having a conversation makes them feel like they have some ownership and they can actually have a conversation with you back and show them that you're actually listening to them because they may have some good information they need to pass on to you. So the antisocial behavior and peer pressures peak between ages 14 to 16 years old. Smoking, illicit drug use, and unprotected sex are problems that may arise, right? So having that talk with them and letting them know what's good and bad at this point needs to happen. Eating disorders can arise in adolescence as well from an attempt to gain self-control through what they eat. Uh, Adolescents may also show a greater interest in sexual relations. So a code of personal ethics starts to develop based partly on the parents' ethics and values and partially on the influence of the adolescent environment, so what they learn in school as well. Many adolescents are fixed on their public image and are also terrified of being embarrassed. And adolescents are also at a higher risk than other population for suicide and depression. Or they're going through changes. They have boyfriends and girlfriends. They break up. They think the whole life is over. The whole world is over. Things like that. So just be there for them. If you could call for suicidal ideations for these here, and you have to transport them in the back of the ambulance, be respectful. Listen to what they have to say. If they have a plan, you want to know what their plan is. Are they homicidal as well? Do they want to hurt somebody else? So again, get in the back of the ambulance, have conversations, treat them like they're adults. Give them the respect that they deserve, and in turn, they might open up to you and give you information that you're looking for. So the early adulthood, 19 to 40 years, vital signs do not vary greatly. As you can see here, everything kind of stays the same, except now our blood pressures may start to go up a little bit towards the age of 40. We start seeing that pre-hypertension. For some reason, my chat box went down for a minute. I just brought it back up, so I'm just kind of reviewing it really quick. So you guys had some stuff in there. Deb, I can't find yours. I'm looking through the email and I can't see it. So if you don't mind resending that, that'd be great. I'll get you hooked in. All right, thank you. Yeah, Joy, I just saw your message about bronchiolitis. Very scary in a 2-month-old, especially not knowing what's going on. Kids with bronchiolitis, we also talk about epiglottitis is another one that we'll see as well. These are very dangerous for kids and need to be treated appropriately. A lot of these kids that have bronchiolitis or things like that when I'm getting what they call racemic epi or nebulized epinephrine from a medic to kind of open up the bronchioles that way. All right. So going back to this thing. All right. So from ages 19 to shortly after 25 years, the body should be functioning at its optimal level. This should be your peak times. Lifelong habits are solidified. All right, thanks, Joy, for that information. There we go. So the body then is working at peak efficiency, but as early adulthood continues, subtle erosion begins. So disc in the spine begin to settle. The height sometimes shrinks. Fatty tissue and weight increase. Muscle strength actually decreases and reflexes become slower. Psychosocial changes we're going to see in life centers on work, family, and stress. During this period, adults will strive to create a place for themselves in the world. So, and many do everything they can do to settle down. Along with this comes the marriage and family, and despite all the stress and the change, this is one of the more stable periods of life. Keep in mind, this is based on books and reading. For ages 41 to 60, you're looking at the middle adults, where vital signs still remain the same. We are start, maybe taking more care of ourselves at this point. I'm looking at blood pressure stuff, eating healthy, things like that, to maintain decent blood pressures. So we're more vulnerable at this age here to vision and hearing loss, higher chances of getting cancer. Menopause occurs in late 40s, early 50s. Look at other medical problems like diabetes, hypertension, and weight problems are very common in this age group. And exercise and healthy diets can diminish the effects of aging. So if we can exercise and stay healthy, our body will hopefully be tricked into looking like we're still younger. So with that being said, we just gotta make sure we're eating appropriately, staying away from all the fatty foods, the sugars, and actually eating more healthy. Because as we all know, if we eat like we did when we were in our 20s, or some of you probably are still in your 20s, you really can't put the weight off like you could before. Sometimes it's more difficult. So we got to make sure we're taking care of ourselves. And to kind of bring this out for all of us, look at the job we're getting into, firefighting EMS. We've got to stay on the healthier side of stuff. If not, then our bodies are going to hurt a lot more. We have a higher chance because we're doing of cardiac arrest or stroke because of the high stress environments that we put ourselves in as well. At this point, they were also focusing on achieving life goals. To kind of add to that, that's why I've already applied to nursing school to make a change at some time in my career. So there are a lot of things that are there. We start looking into achieving different life goals that we've had. Middle adults must readjust their lifestyle as children leave home. So again, at this point, kids are starting to get ready to go on their own. They're going to college. So that finances become more a worrisome issue. Generally, people of this age have a physical, emotional, and spiritual reserve to handle life issues. Middle adults may also find themselves caring for children, leaving for college, and caring for their aging parents as well. So we're starting to see more of a stressful life during our middle adulthood. Looking at our older adults, 61 years and older, the life expectancy is constantly changing. Now approximately 78 years old, based on numbers, is the average life expectancy now. Remember that in the mid 1900s, life expectancy was only 47. Now we're at 78. The age at which a person will live is based on many factors, including the year of birth and country in which the person lives, public health advances, changes within diets, attitudes regarding exercise, advances in access to medical care and personal behaviors. Cancer is the leading cause of death at ages 61 to 65, with heart disease leading cause of death at 65 and older. So we get a lot of patients in their mid 60s that are having heart attacks and things like that. So again, take care of yourself. Vital signs are dependent on the patient now because of the overall health, medical conditions, medications. And remember, look at their medication list. Remember, it's part of your sample history because medications can give you a whole list of what could be going on with them based on their history. That's why they're taking the medications that are there. But it can also decrease blood pressure. Beta blockers, some people are on beta blockers to control their blood pressure, can also decrease the heart rate. So it may mask the symptoms of shock and other symptoms that could potentially cause what you would look for as tachycardia, but the patient might have a normal heart rate because of the medications they're on, masking a symptom. So again, look at their med list, very important. Cardiovascular system then starts to decline with age, largely due to arteriosclerosis. Heart rate and cardiac outputs then tend to decrease. So cholesterol and calcium build up inside the walls of the vessels, forming plaque. Accumulation of plaque then eventually leads to partial or complete blockage of blood flow. These are where we're going to start seeing our heart attacks, our chest pains. So more than 60% of older people older than 65 years have clogged artery disease. Other heart rate and cardiac output decreases at this point, so cardiac output can no longer meet the demand of the body. With that being said, the vascular system then becomes very stiff. The diastolic blood pressure then increases with age as well. Remember, that's our arteries at rest. We want to keep it low. We don't want to have it high. The heart must also work harder to move the blood effectively. If we have blockages, the heart has to pump harder to pump through, right? So the ability to the ability to produce replacement blood cells declines as does the blood volume as well. So the older you are, the less blood you're carrying in your system, and the less chance we're going to have platelets and everything else moving through to prevent clotting. Another thing that happens with elderly as well is they start developing irregular heart rhythms. They could be put on a blood thinner. So this also can make things more difficult for us when we're doing our assessments as well. The respiratory system, as the size of the airway increases, the surface of the alveoli decreases, right? So we're starting to lose that surfactant, which was what helps provide the elasticity of the alveoli to expand and contract in order to take in that oxygen and be able to move. Breathing becomes more labor intensive, and the changes in the respiratory system are often gradual and go unnoticed until a severe life-threatening condition does actually happen. So within the mouth and nose, there is a gradual loss of mechanisms that protect the upper airway. And this leads to the decreased ability to clear secretion as well as decreased cough and gag reflexes as well. Aspiration obstruction has become more likely. So again, they can swallow, but they don't have the ability with that smooth muscle to be able to push that food down the esophagus into the stomach so they can choke easier. Also, they have a higher risk of aspiration, getting fluid or food into the lungs. By age 75, vital capacity may amount only 50% of a younger adult's vital capacity. Loss of respiratory muscle mass, increased stiffness of the thoracic cage, decreased surface area available for the exchange of air, and residual volume starts to increase. We're going to touch more on this stuff when we get more into the geriatrics. But a lifetime of breathing, especially breathing air with high levels of pollution, causes the accumulation of pollutants in the lungs. So look at people's history. What kind of work did they do when they were younger? Were they working in coal mines? Were they working in maintenance garages, breathing in all these fumes all these years? There's a lot of things that are out there you got to pay attention to. With that, the endocrine system, which increases an insulin production, then drops off, and metabolism starts to decrease. So people tend to slow down their physical activity, but tend not to decrease their food intake. So they're bringing too much food in, and their body can't break that stuff down based on the insulin production. The pancreas may not be able to produce enough insulin for the person's body size, which then can lead to diabetes mellitus. And the reproductive system changes to some extent as well. So men are able to produce sperm long into their 80s, but the rigidity of the penis then tends to decrease over time. So that's where erectile dysfunction medications can come into play. An important question to be asking as well because of this, because if we're going to have a patient that has chest pain and they're on ED meds, we can't give that nitroglycerin. Women have a decrease in the size of their uterus and vagina, and hormone production for both sexes gradually decreases as they age. Sexual desire may also diminish, but does not cease. With the digestive system, the taste sensations tend to decrease. Saliva secretions decrease as well. Therefore, they're going to become very dry. The ability of the intestines to contract and move food diminishes. That's why we see a higher chance of bowel obstruction in more of the elderly than we do anything else. Gastric acid secretions tend to diminish. Therefore, we're not going to have that gastric acid breaking down the food. Gallstones become increasingly common, and the anal sphincter changes and can produce fecal incontinence as well. With the renal system, we talk about filtration function starts to decline. So one of these lab tests they do for these, what they call a GFR test, they look at the kidney functions in the renal system to see if they can receive certain things. So what they call a GFR test, which has to be greater than 60% for this. Kidney mass then decreases by 20%, which also decreases the ability to clear waste from the body. We'll go back to the kidney mass decreasing as well. This is due in part to the decreased effectiveness of the blood vessels that supply the blood to the nephrons within the kidney. So we start seeing that 20% decrease. Also, there's a decrease in the ability to conserve fluids when needed as well. That's why when they have extreme bouts of diarrhea, they can't replenish that fluid back. Therefore, they become extremely dehydrated. And if they become dehydrated, that can throw their electrolytes off, which then can cause cardiac arrhythmias. So something else to add into that. The nervous system, in the central nervous system, the brain weight may shrink 10 to 20% by the age of 80. Our motor and sensory neural networks then become slower. Neurons then become lost, but there is not a loss of knowledge or skill, and your sleep patterns may also be changing as well. So the nervous system, you can look at the pictures here. Age-related shrinkage creates a void between the brain and the outermost layer of the meninges, as you can see looking at the picture here in that close-up. So as you can see, the younger adult being on top versus the lower adult, you can start seeing some decrease as well. And also with bleeds is another thing that can happen as well, which is very dangerous as well with a subdural hemorrhage. And increased blood flow here can put pressure on that brain. By doing so, that can change a lot in symptoms based on stroke-like symptoms, sorry. Peripheral nerve sensation now becomes diminished, which then increases reaction time and causes longer delays between stimulation and motion. The resulting slowdown in reflexes and decreased kinesthetic sense may also contribute to the incidence of falls and trauma. We got to be very careful with falls, right? Because as you know, the reflexes and kinesthetic senses are decreasing. If they fall and strike their head and they're on blood thinners, they have a high chance of having some type of bleed, whether it be a subarachnoid, subdural, things like that. So we got to keep that kind of stuff in mind. Do your best not to sign a patient refusal on a fall, especially if they're on blood thinners or elderly. And one of the numbers to look for is greater than 65 for a fall. But if they're on thinners and they strike their head, there's a high chance they could have a brain bleed from that. So you want to make sure you get them to the hospital so they can get a CT scan done to see if there's any blood. You're going to have some sensory changes as well. Most older adults can see and hear well, but they may need glasses or hearing aids as well. Visual distortions are very common with this age, and hearing loss is 4 times more common than vision loss, right? Some of the psychosocial changes: until about 5 years before death, most people retain high brain function. In the 5 years preceding death, mental function is presumed to decline, so a theory referred to as terminal drop hypothesis. As the elderly population then continues to grow, we have the responsibility to accommodate their needs during their last 20 to 40 years of life. Right? We need to accommodate for them, do the best we can to help them out. Statistics indicate that 95% of the elderly live at home. We're going to get called to these homes because they could be lonely and they want someone to talk to. So let's make that happen. When we get there, let's talk to them. This is where community paramedicine really comes into play at this point. Or having like senior centers and things like that where they can get out and actually have social interaction. That interaction, believe it or not, will help them stay alive longer. So the increasing number of elderly in the United States as a result of the baby boom of the 1940s and 1960s has produced the need for additional assisted living facilities. So financial limits may restrict access to health care or medications. So kind of keeping that stuff in mind, they may not have the ability to get the health care they're looking for. Remember that hospital emergency departments are not catch, treat, and keep forever, right? They're not social workers. They're not a nursing home. They're not assisted living. They're going to catch and release. They're going to bring them in, and they're going to release them back home if they're better. If they're not stable or they're sick, they can keep them overnight, but it's something that's going to be long term. So we're going to get called to nursing homes. We're going to get called for inter-facility transports back home. We're going to have to deal with all this kind of stuff as well. More than 50% of all single women in the United States who are 60 years of age or older are living at or below the poverty line, based on numbers. Elderly need to face their own mortality. That's one of the most important issues of the elderly that they deal with. Isolation and depression can be be challenging. Excuse me, as well. Some things to keep in mind, especially if all their family members have passed on, they moved away, and they're home for the holidays, you start seeing a higher suicide rate during that time frame, mostly between Thanksgiving and Christmas. Because those are the times where families get together and enjoy, and a lot of them just don't have family anymore, or they kind of get forgotten about. All right, so let's go over review questions here, and then we'll start out the next chapter. When providing a bagged mask ventilation to an infant, what is the most important to remember? A, B, C, or D?
B.
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 All right. So I was going back to the comments really quick, and I'm looking at Deb's comments. Dave, I agree. Just so you know. All right. So the correct answer is B. Let's see. Number 2. You see an infant capable of reaching out to people and drooling. She is most likely with age group?
B, 4 months.
Seeing a lot of C's pop up, and C is the correct answer. Number 3, an infant who has repeatedly rejected experiences. What type of attachment?
The anxious avoidant.
So repeatedly rejected.
Can't be that easy to be rejection attachment.
Anxious avoidant attachment. Nice job. Number 4. Why do colds develop so easily in toddlers and preschoolers? Read the answers first. All right, D it is. Number 5, the pulse rate of a toddler is?
B.
All right. B. Number 6, a school-aged child looking for approval from his peers in society is demonstrating what kind of reasoning?
Conventional.
Let's see, A's and B's both popping up. So the correct answer is B, conventional. Nice job, Deb. All right, number 7. Self-concept is
I think that's how we fit in.
so the correct answer is A, how we perceive ourselves, self-concept. Number 8, why should you be concerned about a 16-year-old patient who seems depressed?
D.
Trying to read the comments here. C, suicide. Higher chances of depression. Number 9, why do finances become an issue during middle adulthood?
A.
A lot of A's. A is correct. Why is breathing more labor intensive for the elderly?
All of the above, D.
Yep, D, all the above. All right, so why don't we come back at 8:30 and we'll finish up the last chapter. Stop recording.
This conference will now be recorded.
So we're looking at the medical overview on chapter 14. With that, we have we're going to kind of be covering like kind of overview of what we're going to see and talk about the different medicine. We're also going to look at the assessment and management of the medical complaints. So we're going to see like sample, OPQRST, all those acronyms are going to come back. And again, like I said before, you're always going to see these. These are not going to go away. It's common practice. So we're going to look at the standard competencies, and looking at the assessment, the pathophysiology, and assessment and management of the medical complaints to include transport mode and destination decisions. Infectious disease as well, and the awareness of a patient who may have an infectious disease, which I'm sure we know a lot about now, and assessment and management of a patient who may have one. So patients who need EMS assistance generally have experienced a medical emergency, a traumatic emergency, or both. Medical emergencies involve illnesses or conditions caused by a disease. And remember that it is important to remember that the patients may have a combination of medical and a trauma condition. So do they have a stroke and fall? Do they have a single episode fall and cause a head bleed based on trauma? So a lot of different things that are there that could potentially lead to this. Some types of medical emergencies, obviously respiratory emergencies, which they occur when patients have trouble breathing, or when the amount of oxygen is supplied to the tissue is inadequate. We start seeing that shock or shock-like symptom. Diseases that can lead to respiratory emergencies also include asthma, emphysema, chronic bronchitis, like the COPDs. Cardiovascular emergencies are caused by a condition affecting the circulatory system. Common examples would include like a heart attack, congestive heart failure. Then we look at neurogenic or neurological emergencies, which involve the brain. That could look at seizures, stroke, fainting, which is syncope, or GI issues like appendicitis, diverticulitis, pancreatitis, and many others. You notice how all those had itis at the end? Because we're having an inflammation in that area causing significant pain. Right? So we're going to see a lot of these as well. The thing is that part of our job as an EMT is to be able to figure out what is wrong with them. We also have urologic emergencies like kidney stones, endocrine emergencies, most commonly caused by complications of diabetes. We have hematologic emergencies, which may be a result of sickle cell disease or blood clotting disorders, such as hemophilia. Immunologic emergencies, which involve the body's response to a foreign substance. Allergic reactions, remember, are a type of immunologic medical emergency that can range from fairly minor to life-threatening. Toxicologic emergencies, including poisonings and substance abuse resulting in their types of medical emergencies. Toxidromes are the best thing to remember to figure out kind of like where the patient's kind of going and what there potentially could be for a toxin. Gynecologic emergencies are a special category of medical emergencies that involve in the female reproductive organs. Some medical emergencies are also caused by psychological or behavioral issues and may be especially difficult to deal with because patients do not present with typical signs and symptoms of these. So we kind of really need to pay attention to what we're being dispatched to and getting there and doing a full assessment of the patient to kind of see which path we're going to go down on this medical expedition. So we should be able to figure out kind of where our treatment plan is going to go based upon questioning, sample, OPQRC, vital signs, chief complaint, all these things that keep coming back and back and back are going to help us make a determination. And here's kind of like a chart of types of medical emergencies we're going to come into. So looking at patient assessment, similar to the assessment of the trauma patient, but with different focus. We're going to focus on, instead of mechanism of injury, we're going to focus on the nature of illness. We're going to look at the symptoms. We're going to look at the chief complaint. Not what dispatch tells you, what the patient tells you is wrong with them, all right? So we're going to figure out, why are we here today? That is the question, not what, not who, why. Why are we here? And have them give you that answer. We need to establish an accurate medical history, okay? If we can't get one, we can't get one. Sometimes the patients have no idea that they have dementia or things like that. But we need to know what the medical history is, because that's going to help us determine our treatment plans. Use dispatch information to guide initial response. Do not get locked into a preconceived idea of the patient's condition, okay? Injuries may distract from the underlying condition that's actually there, okay? So you need to pay attention to your assessment, all right? Tunnel vision may occur when you become focused on one aspect of the patient's condition and exclude all others, which may cause you to miss an important injury or illness that's actually there. You have to find the underlying condition of why we are actually being called. So remember that assessment may be difficult with uncooperative or hostile patients. We have to maintain a professional, calm, non-judgmental demeanor, right? Do not label patients. Please refrain from that. A frequent caller may have a different complaint this time. We go to what we call frequent flyers. That's what we call them, okay? Probably not the best term to be using. Okay, we've gone before for falls, and then one of the cases we had on the company that I worked for at one point in time in my career, I can't mention names, they went back for a lift assist again to a home, and they get there and the patient's in cardiac arrest. They had called for a fall, typical fall. We always go for falls, all right? I just went to one the other day, and it ended up turning into being a very difficult call. We were called for a Bravo level fall, and let me tell you, a lot of things went wrong with that patient. So again, just because you go there all the time for the same thing doesn't mean that they don't have a different medical condition happening. All right, so don't label the patients. So first thing we're gonna do is scene safety BSI, scene safety BSI. Get used to saying those words. You have to say it before you start your assessments. Make certain the scene is safe. Use your standard precautions. Wear a mask, wear your gloves. How many patients and whether you need additional help. If you have 2 patients, you need 2 ambulances, right? Nature of illness. What is going on? What has caused this illness to happen? Are there multiple people sick? Is there a gas leak somewhere, right? Index of suspicion, your awareness of potentially serious underlying injuries or illness. What do you think is going on? What does your gut feeling tell you? And then also initiate spinal mobilization if you need it. Okay, if you don't need spinal mobilization, then don't worry about it. We're going to develop a general impression, perform a rapid exam of the patient, looking for visual clues, which include apparent unconsciousness, obvious severe bleeding, and extreme difficulty breathing. Quickly determine the patient's level of consciousness using the AVPU scale. Remember, alert, verbal, painful, unresponsive, right? That's how we're going to determine a level of consciousness. Then we get into our ABCs. In a conscious patient, in conscious patients, ensure the airway is open and that they are breathing adequately. Have a conversation with them. Talk with them, right? Check the respiratory rate, depth, and quality. Right? They could be breathing, but are they breathing rapid, shallow, labored, irregular patterns? Are they tachypnic? Do they have slow respirations? These are some things we need to look for in our assessments. Consider applying oxygen if breathing has been affected. For an unconscious patient, make sure the airway is open using proper techniques. We have OPAs, NPAs. If they have a gag reflex, put in a nasal airway. If they don't, put it in an oral airway. This can take several seconds to evaluate their breathing. Don't just look at it and say, oh yeah, okay, they're breathing. That's good. Look at it. Listen to it. Take a listen to their lung sounds. Right? See what's going on. Apply oxygen to the patients that are in shock with difficulty breathing or low oxygen saturations are measured. Even if they have an oxygen saturation of 99%, if they are short of breath, give them oxygen. Remember, there are other things that can give you false readings on patients that have normal pulse oximetry with shortness of breath. Can you guys name two that could give you a false reading? Give me two examples of what can give you a false reading with that. Okay, nail polish can give you bad readings. Tandra put down carbon monoxide, right? CO2, which is not. I'm trying to think of CO. So if you have, maybe carbon monoxide. I'm trying to think if you had a high exposure, that wouldn't do much at all. Another one is anemia. If a patient's anemic, can it give you a false reading as well when they actually do need oxygen? But a big one, though, is definitely carbon monoxide poisoning. Circulation. So we're going to assess this in a conscious patient by checking the radial pulse. We'll look for rate, rhythm, and quality in this. We're also going to look at the patient's skin color, temperature, and condition. Remember, if they're pale and diaphoretic, they're not getting enough oxygen to the cellular level. We're not getting that gas exchange that we need, right? So look for pale, diaphoresis. Are they really hot, red? Are they hot to the touch? So look at their skin color and temperature, and then look at the patient's pulse as well. And look for rate, rhythm, and quality. Is it a bounding pulse? Is it a weak pulse? Is it weak? Is it thready? Is it rapid? Is it slow? Is it irregular? If there's an unconscious patient, check the carotid artery. Then we need to make a transport decision. So patients in need of rapid transport would be your unconscious or have an altered mental status. Patients with airway or breathing issues. Patients with obvious circulation problems such as severe bleeding or signs of shock. If the patient does not meet the criteria for rapid transport, continue your assessment on scene and prepare for transport when you have completed the assessment and treatment, right? So that's the let's get up and go, or can we stay and play a little bit, right? So look at your transport decision. And where are we going to take this patient? Now we get into history taking. This is where our sample and OPQRST mnemonics come into play. So again, determine the problem of what problem is or what may be causing the issue. So gather history from the patient, family, friends, bystanders. Investigate the nature of illness by inquiring about the chief complaint. Ask about the history of the present illness and ask for follow-up questions. Do you have any pain? Yes. Where is the pain located? In my stomach. Does the pain radiate anywhere? Well, it goes to my right lower quadrant. Have you had your appendix removed before? No. Things like that. On a scale of 0 to 10, how do you rate your pain? Well, it's a 6, right? What does the pain feel? Is it sharp? Is it dull? Is it a pressure? Is it a stabbing pain? You want to ask these follow-up questions to kind of help you tailor what your assessment and treatments. So we look at obtaining a sample history. Remember, signs and symptoms, allergies, medications, pertinent past medical history, last oral intake, events leading to illness or injury. OPQRST, onset, provocation, quality, radiation, severity, time, right? We have to have these on all of our medical patients that are able to answer. Record any allergies, medical conditions, medications. Remember, some patients take numerous meds. You take the medications with you to the hospital, right? Determine if the patient is compliant with his or her drug regimen that they have, right? So just because they're on medications doesn't mean they actually take them, right? So you have to find out, are they compliant with their meds? If they have high blood pressure, you take it, in the afternoon, and they say to you, oh, well, I haven't taken my medications in a month. Okay, well, that'll explain why you're hypertensive, right? So that's what you want to figure out. Remember this one here, TACOS, T-A-C-O-S, tobacco, alcohol, caffeine, over-the-counter medications, herbal supplements, sexual and street drugs, right? Scan the scene for clues about the patient's medical history that might help you understand the current medical emergency that's actually there. Look around, look on the countertops, look on the floor. Remember how I mentioned before, be careful, because if they're shooting up and they drop their needles on the ground, you kneel down and take that needle into the kneecap, last thing you want to happen. Is it not changing? There we go. It may occur on scene or en route to the hospital with your secondary assessment. In some cases, you may not even have time to get to it. Remember, if you have an ABC problem, you control bleeding, and you're trying to fix their airway, you may not get on to the full assessment. All right? You got to treat life threats first. As far as your physical examination goes, all conscious patients should undergo a limited or detailed physical exam. For unconscious patients, always perform a secondary assessment of the entire body or the head to toe. Remember how we have our rapid, I talked about rapid assessment, and then I have the secondary or detailed assessment. Those are our head to toe assessments, but one is done within 60 to 90 seconds. The other one is done within like 3 to 5 minutes, doing a detailed assessment going right down through. We're going to examine, so as far as our physical examination goes in the secondary and or rapid, this is more looking closely at stuff. Examine the head, scalp, face, head, ears, eyes, nose, throat, or what they call HEENT. Examine the neck closely. What we're looking for is tracheal deviation, any jugular vein distension. Palpate the back of the neck. Feel for any step-offs in the cervical spine. All right? We're going to assess the chest and abdomen. We're going to make sure there's equal rise and fall with this. Okay? Equal rise and fall, good chest expansion. We're going to feel for any crepitus. We're going to look for any kind of flail segment. Okay, flail segment is two or more ribs broken in order. Okay, so we're going to feel for that flail. We're going to look for the neck for accessory muscle use as well. When we do the neck assessment, looking for breathing difficulty. We're going to palpate the legs and arms, looking for what they call decap BTLS. Yeah. This is being recorded as well, so you can listen to this if you want. So when we're assessing the arms and legs, we're looking for decap BTLS. Remember, deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, laceration, and swelling. Then get a good CSM check as well. So check their sensory, motor, and wow, I'm drawing a blank. Circulation, motor, and sensory function. So checking for pulses, cap refill. Can they push up and pull down on the feet? Pull up, push down. Do they have good equal grips? You know, looking for good CSMs. Then check for range of motion. Can they move their arms around in circular motions? Can they move as they're supposed to? Is there any pain when they do that? We're going to assess the patient's back. As we're assessing the back, we also want to make sure we're checking breath sounds. Check a good set of lung sounds on their backside, right? And as we're assessing lung sounds, we don't want to go up and down one side. Cross over in a Z pattern so we can have comparable sizes. We're listening to our lung sounds, right? When you assess the abdomen, don't just push on the abdomen once. Actually check all 4 quadrants. If they're complaining of right lower quadrant pain, you want to ask them, is your appendix still in? If that's the case, you want to push down at McBurney's point. McBurney's point, if you locate the navel and you measure 3/4 of the way down towards the pelvic bone, and you push hard in that one spot, push down deep, that's where the appendix is located. That's what they call McBurney's point, right? You're going to have a lot of significant rebound tenderness. You're going to have inflammation, right? And that's when we have our appendicitis patients. If we have patients that complain of like gallbladder issues, or let's say they have liver issues, where are you going to find the liver? Where is that going to be located? Well, underneath the rib cage on the right-hand side. But check that, have them take a deep breath in. And as they're exhaling, take your fingers and roll them underneath the rib cage and palpate the liver. On normal, you should be able to palpate 2 to 3 centimeters of a liver every single time. Remember that in pediatrics, also to add to that, that's one of the first signs of congestive heart failure in a pediatric, is you're going to see an inflamed liver. So something to pick up on as well. When you're assessing the patient's back, also palpate down the spine. Remember, we have 33 vertebrae, right? 7, 12, 5, 5, and 4. Looking at cervical, thoracic, lumbar, sacral, coccyx. Remember that your sacral and your lumbar are fused, okay? They're fused vertebrae. All right, so L1 through L5, all fused as one big block. All right, so you want to make sure you palpate down. You're going to feel for any kind of step-offs and feel in the spinal processes as you go down the back. With vital signs, we want to make sure we're checking not just like blood pressure, heart rate, respiratory rate. Right? Get a blood glucose in these patients. Get a blood pressure, heart rate, lung sounds, pupillary response. You know, get all these things in order. Entitled as well. You know, look at all these different tools that you have in your toolbox and come up with a treatment plan. So anytime you assess something like a heart rate, rhythm, and quality, is it regular, irregular, or regularly irregular heartbeat? Do you feel any skip beats? Looking for respiratory, is it equal rise and fall, or is it an irregular respiratory pattern? Looking at your blood pressures, are they hypertensive, hypotensive? And if you have a cardiac monitor, you can actually get the mean arterial pressure as well. One of the things we look for a MAP, mean arterial pressure, is if it's less than 64. That's one of our signs and symptoms of sepsis, actually severe sepsis, getting almost into septic shock. So the blood pressure is actually that low. Blood glucose level, pulse oximeter reading. Remember that our normal readings are not 94 to 100. We don't want to have anybody at 100%, right? Especially COPDers. COPDers live around the low 90s, right? Now, is it going to hurt them to put them at 98% for a short term? Absolutely not. It's not going to do anything to them at all. But if you put them on a non-rebreather and they sit on a non-rebreather for 24 hours, that can hurt their system tremendously. Because remember, they are CO2 retainers. So they retain carbon dioxide. So we don't want to flush that out of their system. As far as the reassessment goes, this is performed once the assessment and treatment have been completed. All right. So at this point, we're going to consider ALS backup. So do you need a paramedic or not, or an advanced EMT? We're going to reassess our intervention. So if we did an intervention, okay, we're going to reassess that to make sure that it's going appropriately. Vital signs will be continuously taken every 15 minutes for stable, 5 for unstable, and that's going to build our trend. And then when we're trending, we're going to see if the patient's either getting better or worse. If we give a medication as an intervention, I want to see what the vital signs were pre and post the intervention that we did. One of the biggest ones is nitroglycerin, and because you can do 12 leads and nitro as an EMT, before you start popping nitro into somebody, get a 12 lead. If a patient is if the patient's heart's ischemic, okay, it can either get better on an EKG or it can get worse. Either way, it has to go from being low to being high on an EKG. So you want to make sure you get that 12 lead before you give nitrates, right? Then 5 minutes after the nitrates have been given, then repeat a 12 lead, and then hand those 2 to the ALS provider and say, this is what I got pre and post, right? Because sometimes things can change. Then document any developed changes that you may have, right? Please do not half-ass your run reports. Be detailed with these, right? Most medical emergencies require a level of treatment beyond that available in the pre-hospital setting, right? Because they require advanced testings available in hospital settings like CTs, lab work, things like that, ultrasounds, things like that can be done in an emergency department, which may be beyond the scope of an EMT to administer medications to a patient, therefore having a paramedic en route. Patients that are septic and need antibiotics. We do not carry antibiotics in the ambulance as of yet. All right. And remember the EMTs, you guys can use AEDs. Okay, we cannot go into manual functions. As far as management and transport of the destination, our scene time may be longer for medical patients than for trauma patients. So we may have to have more time looking at what's wrong with the patient itself. So we're going to gather as much information as possible to transmit to the emergency department. Critical patients always require a rapid transport. So very young, very old. Patients with altered mental status require rapid transports as well. Anything with airway or breathing difficulties. Patients with any signs of circulatory compromise. So severe tachycardia, if they have pale diaphoretic skin, if they have bradycardia, low heart rates, if they're hypotensive, severely hypertensive patients that can cause a stroke very quickly. Patients that are very old or very young need to get to the hospital. So a lot can go wrong in a short amount of time. And the older you are, or the younger you are, you have less chances of compensating. With a young kid, they can compensate very well, but when they stop compensating, they stop compensating. And we start seeing that big decrease. Let's see. So the type of transport, obviously life-threatening condition will be lights and sirens. Non-life-threatening condition, consider non-emergent transport. Please do not transport patients lights and sirens unless they need to go lights and sirens. All you're doing is putting yourself at risk, your patient at risk, and if there's an accident and they find out your patient had a nosebleed and you're transporting lights and sirens to the hospital and someone gets killed, you're going to be in a lot of trouble. I can tell you that right now. There's 2 modes of transport ultimately come in one of 2 categories, either ground or air. You can consider air medical transport, but it needs to be justified. So patients that are having strokes, heart attacks, traumatic injuries, those may require air medical transport to a specific specialty resource hospital. So if you're working in the area that I work in, we have critical access. So the critical access hospitals we have are Huggins Hospital and Memorial, right? They cannot handle STEMI patients, patients having heart attacks. They can stabilize. They have the ability to give TNK, Plavix, heparin. They can get that kind of stuff going, but there's no cath labs where they actually need to be able to get a balloon put in and be able to get a stent placed, right? Stroke patients, again, critical access hospitals do not have neurointervention. right? So they may have to go to they're going to go to a stroke center that has neuro capabilities with a neurosurgeon. But local hospitals do have the ability to give clot busting like TPA. They have the abilities to give CAT scans or CTs of the head to see if there's any bleeds. So again, you got to play it by ear and the stability of the patient. And if you can get a paramedic on board, they can make the decision to bypass. So ground transport EMS units generally are staffed by EMTs and paramedics. And our air medical transports are usually staffed by critical care professionals like critical care nurses, some carry respiratory therapists, depending on where you work and what system, and then paramedic and critical care medics. So for like Boston Medflight, Life Flight of Maine, Dartmouth, UVM's helicopters, if you're close to the Vermont side, they carry a nurse and a paramedic and a flight. Boston Medflight actually has 4 staff on board, so they carry 3 in the back, 1 in the front. It's all based on the size of the helicopter and how they can transport. So if you've got a patient who's out in the middle of the woods with a hip fracture or femur fractures that are critical patients, your closest trauma center is an hour and a half away. The helicopter can get to a trauma center from here where we are in 15 minutes, which could be an hour and a half transport for you. So again, you got to play it by ear, all right? And what you have going on, where you can land, things like that. What do you need for resources? Destination selection, generally the closest hospital should be your destination. But there may be times where the patient needs to go to a different center. All right. So with that being said, if you're in the area we are and you have a patient that has an obstetrical emergency, Huggins Hospital can't take that because they don't have an OB. They don't have labor and delivery. But Memorial and Frisbee do. So we may have to bypass, go to a different hospital that can take that patient. Even Laconia doesn't have labor and delivery anymore. They have to go to Concord. So know your areas that you have that have labor and delivery. If you're in the Sanford area, Sanford Medical Center doesn't have an L&D ward. They don't have anything. It's just an emergency department. They have to go to Biddeford. So again, know your areas, know your hospitals, and where you can and can't transport. So infectious disease. So we know a lot about this, at least with COVID anyways. We deal a lot about the infectious disease with COVID response and how we're going to dress and everything else. We went through this when we had the Ebola, which didn't last very long at all. We spent a ton of money on suits we ever wore. Yeah. So approach like any other medical patient, but remember to perform a scene size up, take standard precautions, and complete the primary assessment. We're going to gather history using OPQRST and elaborate on the patient's chief complaint. So again, we need to find out why we are here. Right? Dispatch may tell you one thing. Prime example today, I had a call this morning. We had called for an unconscious patient, right? Unconscious on the floor. We get there and she was literally just sleeping and just needed to lift assist back onto the couch. So we got told unresponsive, Delta level unresponsive patient, and really it was a sign here, you don't need to go to the hospital because they don't want to go. They just want to help getting back onto the couch. So again, find out what's wrong with your patient. Use dispatch's information to help you, but again, chief complaint is what the patient tells you, not what the dispatch tells you over the radio. So typical chief complaints would also include fever, nausea, pleuritic chest pain, rash, difficulty breathing, vomiting, and diarrhea for infectious disease. So we're going to obtain a sample history, get a set of baseline vitals. We're going to ask whether the patient has recently traveled or has come in contact with someone who has traveled, right? We tend to have gotten away from that. We still need to ask these types of questions. Have you traveled outside the U.S. or anywhere in the U.S. within the last 2 weeks? We're going to general management principles, obviously focus on any life-threatening conditions, so ABCs. Remember that you can skip airway if they're bleeding out, okay? Because if they bleed out, they're dead anyways. So throw a tourniquet on and then move forward back to airway. Be empathetic. Place the patient in a position of comfort on the stretcher. Remember to keep them warm and use standard precautions, right? position of comfort. If it's on their side, then it's on their side. If knees are bent, the knees are bent, laying down, sitting up, right? The only thing we don't do is we don't put them prone, face down, right? Because that can cause a lot of issues, especially if they have positional asphyxia and they end up dying, right? So position of comfort. So a little bit about epidemics and pandemic considerations. So as you know, we have went through the pandemic. We've seen it. It was a global scale COVID, and it's still hitting us now, right? I'm not going to bore you guys to death on COVID. I've sort of seen enough of it in the news, what we've read, what's fake, what's real, whatever you guys want to believe, right? But let's go to the next slide, though. Influenza. Really big, almost non-existent in 2020. Non-existent with flu, right? What's making a comeback right now? The flu, right? So the flu is coming back, right? And it's going to start becoming very serious because what has happened? People didn't get flu vaccines because they were wearing masks. They got the COVID vaccine. It's not the flu vaccine, right? So now we're going to start seeing patients with flu-like symptoms. Working in the ER in 2020 to 2021, I think we saw one case of flu, right? When normally you'd probably see 30, 40, 50 cases, throughout the wintertime, if not more, right? People are not wearing masks anymore, and now the flu is making a comeback because people didn't get their flu vaccines. So something to pick up on, something to think about, and protect yourselves. Yes, Deborah, I just looked at your thing. Stanford does have a great psych trauma team. You're right, that is correct. Sorry, Joy, to answer your question, do you think that's just because people didn't go to the hospital? If they had the flu, most likely they were going to go. We even had people come in and we would do something called a fourplex, which was flu A, flu B, COVID, and RSV. So did all four based on one swab, and we were just not seeing the diagnosis of the flu. We had a lot of patients come in though, respiratory symptoms that presented just like the flu, and they were diagnosed with COVID, and did not actually have the flu A or flu B virus inside them. It wasn't common anymore. And then now we're starting to see it come back with a vengeance. So the CDC is actually recommending now that people actually get their flu vaccine now. And granted, it's late in the season, but they're saying they're seeing it a lot more now, especially with our weather patterns that we've been having up here. We kind of add to that. So those with chronic medical conditions, compromised immune systems, and the very young and very old are the most susceptible to complications of influenza. These are transmitted by direct contact with nasal secretions and aerosolized droplets and coughing and sneezing by infected people. So wear your masks. How we got along for so many years without wearing masks for all these years prior for EMS before this COVID came out, I don't know how we didn't get more sick, honestly. H1N1, the swine flu, back in 2009, I remember going through these here. They're present for years in animals. This caused many deaths. So the swine flu became really big. Everybody thought someone would turn into a pig. Never actually happened. But it caused a lot of deaths and increased awareness of routes of transmission because we became very lax in what was going on. So for diseases that can be passed by the respiratory route, always wear PPE, HEPA respirators or N95 masks, eye protection, gloves. Again, even surgical masks can help, but again, it can be very difficult if we're not protecting ourselves. So we do carry N95s. The Envo masks, we tell you, they're very good, but you got to spend the money on them, $80 a piece, roughly, but they're worth it. Or you can wear cappers, pappers, things like that have constant flow that can last a little bit longer. The commonest virus strains carried by humans, of individuals carrying the virus, 80% are asymptomatic. This is for herpes simplex. Some comment pop up. Yeah, envos are very nice. Yeah. Symptomatic infections cause vesicles that appear on the lips and genitals. This can cause more serious illness in susceptible patients. Primary mode of infection is through close personal contact, so protect yourself. The HIV infection, EMTs face a risk of exposure. There's no vaccine that yet exists with HIV. AIDS can still be fatal, however, with treatment, patients can expect a near normal lifespan. A lot of things have happened over the years, many, many years of treatments for these. It's not easily transmitted in the work setting. Again, protect yourself. Your risk of infection is limited to exposure to an infected patient's blood or bodily fluid. So again, wear your gloves, wear your gowns. They're all provided to you. All right. Many patients with HIV show no symptoms. Always wear proper type of gloves. Take great care in handling, again, of disposing of needles. So don't recap needles. Please do not stick them in the bench seats. Oh, good Lord, don't do that. If you have any open wounds, cover them before your shift. All right, wear gloves. If you think a patient's blood or secretions may have entered your system, seek medical advice and notify your infectious disease officer. All right. Inflammation. For hepatitis, inflammation is often infection of the liver. Early signs would be loss of appetite, vomiting, fever, fatigue, sore throat, cough, and muscle and joint pains. So if the patient has hepatitis, one of the other things you're looking for is jaundice, which is a later sign, and the right upper quadrant abdominal pain, like I mentioned before, assessing that liver. Look for jaundice first. Usually you'll start seeing the sclera of the eyes, the white part of the eyes will start turning yellow. Also, you'll start seeing yellowish skin as well. So this is a toxin-induced hepatitis, is not contagious, right? There is no sure way to tell which hepatitis patients are contagious at all. We just don't know. So vaccination with hepatitis B vaccine is highly recommended for EMTs. So highly recommend that you get the Hep B series. It's also free to providers. All right, the services have to pay for these by federal law. They have to pay for them. I honestly cannot read this screen. It is so small in mine, I couldn't even tell you what it says. And these more of your rate of infections, incubation periods, as far as hepatitis goes. Meningitis, inflammation of the meningeal coverings of the brain and spinal cord. This can be very contagious, especially if it's bacterial. Viral meningitis, not so contagious at all because it's more viral, but bacterial meningitis, you need to protect yourself. Common signs including fever, headache, stiff neck, altered mental status. When they talk about stiff neck, one of the things you want to test is have them touch their chin to their chest. So they bring their head down. If they have increased neck pain, then that could be a potential for meningitis along with fever and headache. We cannot test for this in the field. They need to do a spinal tap for this and check the spinal fluid. And that's how they're going to check for that. Most forms of meningitis are not contagious. So meningococcal meningitis is highly contagious. So take standard precautions, wear your gowns, everything else. It can be treated with antibiotics in the ED though, but after treating meningitis patients, contact your employer health representative, let them know what's going on with that. All right, let's get into tuberculosis. We're getting closer to the end here. Many infected patients are well most of the time. We should be getting tested for TB every year. What they do is they implant like a subcutaneous injection underneath the skin within 48 hours. As long as it's not red and blotchy and a big circle around it, then you're usually pretty good. You don't have tuberculosis. You can get false positives. In that case, they'll put you through a chest x-ray and they'll read it that way as well. So again, it's a chronic microbacterial disease that usually strikes the lungs. So isn't COVID. So they want us wearing N95 or HEPA masks, right? So consider respiratory tuberculosis to be the only contagious form. All right, so keep in mind of COVID. So don't forget about it. It's still out there. Infectious agents can also hold in some patients more easily because of the reduced defenses. Like elderly patients can hold this longer. Patients who are immunosuppressed from chronic illness, cancer treatments, or organ transplants as well. Absolute protection from the tubercle bacillus does not exist. 1/3 of the world's population is infected with tuberculosis. 1/3 of the world's population. It's a lot. So the vaccine is rarely used in the US, though. We just don't see it over here. Mechanism of transmission are really not that efficient in the US as well, and have tuberculin skin tests regularly. So again, once a year. Preventative therapy is almost 100% effective. Again, you just have to make sure you're getting tested and make sure you don't have it. Whooping cough, also known as pertussis, mostly affects children in the younger ages than younger than 6 years of age. Symptoms do include a fever and a whoop sound that occurs when inhaling after a coughing attack. The best way to prevent exposure is to be vaccinated with the DPT or Tdap. You can also place a mask on the patient and yourself. So again, if you have a patient with any kind of respiratory symptoms, we should be putting a mask over them anyways. All right, so MRSA. MRSA is a bacterium that causes infections, right? You see this a lot with the elderly. I've seen MRSA quite a bit with them. You just got to find out where their MRSA is located, whether it be respiratory MRSA, if it's a wound infection type MRSA. This is resistant to many antibiotics. It's more like the superbug almost, where the antibiotics just can't kill it, right? In healthcare settings, MRSA is transmitted from patient to patient by healthcare providers, unwashed hands. So wash your hands, protect yourself. Some of the factors that may increase the risk of MRSA: antibiotic therapy, prolonged hospital stays, a stay in an intensive care or burn unit, exposure to an infected patient. Makes you not want to be at the hospital, huh? So MRSA results in soft tissue infections, localized skin abscesses, and sepsis in older patients, right? Because that infection. All right, sorry, Joy, I just saw your comment. So they can do boosters. They can also do what they call a titer. After your hepatitis series has been done, they do a titer to make sure it's still there. And then they might have to give you a booster if they're not seeing it, or start you over again. So if you've had the hepatitis B or hepatitis A vaccines started or completed, just go in and get a titer drawn and see if they actually stuck in your system. All right. Some of the global health issues would be the Middle East Respiratory Syndrome coronavirus. So the first human case discovered, ready for the coronavirus, 2012 in Saudi Arabia. All right. The coronavirus has been around for a while. If you actually read the back of those purple top cans that you use to clean stuff with, it actually says kills coronavirus on it before COVID-19 even came out. Common patient symptoms include high fever, cough, muscle aches, vomiting, diarrhea, in some cases, renal failure, respiratory failure, and death. There are no cure or vaccines for this virus at the present time. Now we have vaccines that are out there to help prevent it. And I can't say prevent. That's probably a bad word to be using. You can still contract COVID even with the vaccines, but it's supposed to make the symptoms not as worse as it would be without it. What they were saying on average, the hospitals stay with a COVID vaccinated patient. If they were vaccinated, the average stay in the hospital was 4 to 5 days. The average stay with a patient who is not vaccinated is about 52. 50 to 54 day average. So kind of keep that in mind. All right, a little bit about something with global health. Ebola. The outbreak in Ebola in 2014 in West Africa. The incubation period was 6 to 12 days after exposure. Symptoms may not appear for as long as 21 days after the infection. Symptoms include watery diarrhea, vomiting, fever, body aches, and bleeding. Fatality rate can be as high as 70% if treatment in the ICU is not initiated promptly. We were very fortunate in the US that we did not have a ton of Ebola outbreaks or cases. It was one of those global issues. We put Ebola suits, they were basically the level B hazmat suits for the most part. They were required in all the ambulances. They've taken them off since, but they were there in case you had an Ebola type patient. They had no idea what to do with it. As far as travel medicine goes, we're getting close to the end here. You must be aware of travel-acquired infections when assessing a patient who is recently outside the United States. So if they're sick with flu-like symptoms and they have traveled, we have no idea what they may have acquired from another country. So wear the proper PPE when you go in. Again, another thing to mention too, if you're on shift, you really should be derobing at the base, putting on street clothing, and showering before you go home. The last thing you want to do is bring that crap that you've now acquired or touched in the last 24 to 48 or 72 hours, long as you've ever been here for, and bring that into your own vehicle where your family sits and into your own home. So bag it, bring it home, put it right to the laundry, wash it, clean it. But again, you should be showering before you leave shifts. Again, that's my own personal opinion. Do as you wish. Important questions to ask would be, where did you recently travel? Did you receive any vaccinations before your trip? Were you exposed to any infectious disease? Is there anyone else in your travel party who is sick? What types of foods did you eat? What is your source of drinking water? You know, things like that. So as far as conclusion goes, we're getting to review questions. Assessment and treatment of medical patients can be challenging and interesting because of the nature of medical conditions. I love medical calls because it's interesting. It could be anything. Your job is to figure out what it is. It's a great way to, I like to say, interrogate your patients to get the information you're looking for and come up with a pretty neat treatment plan. And you also have more chances of contacting medical control and having good consultation and follow-up to make sure your treatment plans are done right. Keep in mind and remember that patients sometimes have more than one isolated problem, right? You may resolve one and another one may appear, or it could be masking something else that's already there. So in review, if a seizure patient is having what kind of medical emergency? A, B, C, or D? Awesome. C it is. All right, number 2. If an injury distracts an EMT from assessing a more serious underlying illness, the EMT has now suffered from what condition? All right, tunnel vision. That is correct. Number 3, if a frequent flyer calls 911 because of a suspected head injury, you should never do what? All right, C it is. Number 4, if a medical patient is not in a critical condition, how long should you spend on scene? All right, see a lot of D's, C and A. So remember, is not in a critical condition, okay? National Registry type question. Look for the keywords, not. The answer is D. As long as you need. Number 5, your patient is having respiratory difficulty and is not responding to your treatment. What is the best method of transport? All right, B it is. Number 6, when assessing a patient with an infectious disease, what is the first action you should perform?
Okay.
All right, nice. See and size up, A. Number 7, your patient believes that he has hepatitis and is now exhibiting signs of cirrhosis of the liver. He most likely has which type of hepatitis? All right, very good. Hepatitis C. Answer C. Number 8, your patient is complaining of a fever, headache, stiffness of the neck, and red blotches all over his skin. He most likely has. Remember, your key thing would be here is stiffness of the neck and headache. All right, D, meningitis. Number 9, what should you do if you are exposed to a patient who is found to have pulmonary tuberculosis? A lot of B's. Get the test. Nice. And number 10, all the following are factors that increase the risk of developing MRSA except. All right, D it is. All right, so let me just turn the recording off here.